Hello, thank you for joining us today. I'm Raul Hernandez, and I'm serving as a Director of Conference for the Healthcare Business Association. In this panel, we will discuss the frontline activities to achieve healthcare equity and really consider how a team and organization can move towards this goal. Joining us today to share some of their experiences and insights are Kathi Cervantes, a co-director at Promesa Boyle Heights, Francisco Romero, a manager at Promesa Boyle Heights, Jennifer Law, a senior director at Envision Healthcare, and Myron Soyangco, an operational excellence manager at Sharp Healthcare. To help guide the discussion today, it's my pleasure to introduce Division VP at DaVita and an Anderson alum, Paige Hosler.
Great. Thank you so much, Raul. Really excited to be back with both the Anderson as well as the Southern California healthcare communities for this session today. I have to say I was really struck by one of the quotes from this morning's keynote speaker. And for anyone who wasn't able to join for that, I'll share it, that when it comes to health, your zip code matters more than your genetic code. I thought, man, that is incredibly powerful. And I'll share, I'm especially passionate about the topic of health equity, having spent the last 9 years of my professional career working in kidney care. The unfortunate reality is kidney failure disproportionately impacts individuals from lower socioeconomic status and individuals from underserved communities. So this is very much a reality for a lot of the patients that we serve at DaVita. I'm also very excited to have our 4 panelists today representing 3 organizations who are doing a lot and have a lot of great things to share. My goal for the session is that we can all learn from each other and hopefully come away with really tactical ideas and activities that we can all bring back to our own respective organizations to really start to move the needle here. So with that, let's go ahead and jump in with our first question for the panelists. To facilitate a little bit of introductions, would love to hear from each of the panelists on some of the great work their organizations are doing to address health equity. Let's see, Kathi, let's start with you.
Hi, thank you. My name is Kathi. I'm from Promesa Boyle Heights. And Promesa Boyle Heights is a collaborative, and it's comprised of residents and partner organizations in the community. And if you don't know where Boyle Heights is, it's in the east side, where downtown is, but on the east side. And a lot of people call it East LA, but it's Boyle Heights. And back in 2010, we had this opportunity to apply for a grant. It was a federal grant. We got a planning grant, and our community and partner organizations in the community were so committed and so determined, and they had this huge vision of how they wanted Boyle Heights to look, right, in supporting families and supporting students. And so when it came time to apply, we were just a few points away from getting this huge federal grant. However, this did not stop the residents. One of our popular quotes from a resident is that we made a promise. So from there, our name is born. Promesa means promise. And so even though we didn't have the grants to continue or to get this huge plan started, we had to scale down that vision. And so we started at a high school, and a high school in Boyle Heights, Mendez High School. And there we learned that students were in need of more than just academic supports. And that health equity piece that is so important right now. We realized through many surveys, through check-ins with students, and with residents in the community that, and partner organizations as well, is that students were in need of more than just academic support. There was a lot of social emotional support that they needed, the mental health piece, in being able to navigate resources. And then we started to see that our approach needed to be a whole student approach, like a whole person approach. And then from there, we also realized that, success isn't just happening at a school level. Success also needs to come from the home. And so we realized families needed support in being able to navigate resources for health and wellness. And so I would say like in 2015, we joined a campaign, it was called the Wellness Centers Now campaign. And through, this huge work and determination from residents, mostly a lot of parents and residents from Boyle Heights, we actually were able to win. This was a huge win for us. And that first school that we were working in, we're still there actually, that school was chosen to have a wellness center. And what makes this wellness center unique and special is that it's not just going to be for medical supports for these students, but it's going to be for the whole community. So this wellness center is going to be accessible to parents and residents and just the community at large in Boyle Heights, and not just medical supports, but it's going to contain dental and mental health supports, and it's all located in the school. So we've learned that schools are a hub, and a lot of families of these students come to the school wanting to know, where they can access certain things, certain resources. So it just made sense that this wellness center be at this school, especially in this location where there isn't much around, especially when it comes to clinics or just healthcare in general. So.
Wow.
Thank you.
That's amazing. Sounds like a lot of very relevant learnings there. We'll be eager to hear more. All right, Myron, let's head over to you. Tell us a little bit about what your organization is doing.
Yeah, so good afternoon, everybody. So I'm here representing Sharp Healthcare. For those of you who are not familiar, Sharp Healthcare is one of the larger health system organizations based in San Diego. We operate several hospitals in the San Diego County. Actually, we also operate a hospital that has the busiest emergency room in San Diego County and the 10th busiest in all of California. So as you can imagine, that correlated to that means that a lot of our patients are these underserved populations. This hospital I'm talking about, Sharp Grossmont Hospital, which is actually my home base, covers an area of 750 square miles. That's our encatchment area for people that come to this hospital. So you can imagine what sort of populations we serve, what acute needs we serve in these communities. The other arm, which I think is why a lot of people were sort of interested in getting me to speak here, is that Sharp Healthcare partnered very early last year with the County of San Diego to provide the COVID-19 vaccines in the community. And since then, we have become the majority provider of these vaccines in San Diego County. And we did that by operating, these super sites, similar to what you folks had here at the stadium. UCSD had theirs at their stadium, but we converted an old Sears building to a super station and those sorts of activities. And since then, we have been partnering actively both with local nonprofit organizations and with the County of San Diego at large to not only make those super sites exist, but to develop programs that actually specifically address equity and diversity and inclusion and access to those programs. So for today, I'm going to be very happy to talk about, how do we really have that EDI focus, not only within the four walls of the hospital in that emergency room, but also outside as we go out to the community to provide these ambulatory services.
That's great. Thank you so much, Myron. All right, and over to our third organization. Jeni, would love to hear what the folks at Envision Care are doing.
Hi, happy to share. I'm Jeni. I'm Senior Director for Value-Based Care Product Development at Envision Health. We're a national multi-specialty physician group covering everything from anesthesiology to emergency medicine, women's and children's radiology, and surgery. To this end, we actually serve over 11 million Americans in our emergency departments every year. And it's such a huge number. And looking at value-based care, it's just important to think through who are the patients who are the frequent flyers? Why are they showing up? How can we lower the total cost of care? So that's been a lot of the fun work that I've been involved in. And one of the reasons why I was asked here today was to talk about leadership and how do we hire diversity and how do we get those voices to chime into the process in terms of developing meaningful value-based care programs.
Great. Thank you, Jeni. maybe I'll stick with you for our next question. So as you think about the work your organization was doing around finding the right leaders and building out that program, what were some of the challenges that you all encountered? And really my hope in hearing from all three organizations in terms of some of the challenges is that this can be an opportunity, again, for us all to learn from each other, each other's challenges, each other's failures. So Jeni, I'll stick with you for that question.
Sounds good. Yeah, I think when we're looking at designing programs, CMS is a really great center of innovation and looks at certain models. One of those, for example, is ET3, Emergency Treat, Triage, and Transport. But CMS really only covers the Medicare population. And when we're looking at our patient population who's calling 911, there's so much more that's at stake, and it's not all commercial patients. It's not all Medicare patients. There's a significant number of people who are self-pay and Medicaid. So how do we address those needs? How do we bring that to the table? Organizationally, I think one, it's making sure that we hire right. We actually try really hard to focus on the local community and make sure that we have representation there, whether it's with the EMS partner that we have chosen or with the physician who's leading that group. That's one of the things about Envision is that we actually are really focused on our clinical leadership. And then the other aspect of this is looking at data. I think, and Paige will probably chime in on this a bit, having data is so important because when you don't have the data to back up what you're doing, then you get a monolith of data. You see something like, 60% of our patients treat in place. That data looks a lot different when you cut it by their insurance coverage. And then you start seeing, wait, we actually could treat so many more patients in place when we know if they're Medicaid, if they're younger, or if they're on commercial insurance.
Yeah, you're exactly right, Jeni. We definitely greatly value, the data and the analytics piece. And then I know insurance is also something that we advocate for and educate all of our patients on and I think our keynote speaker this morning also touched on the importance of access to insurance, which opens doors for other important healthcare access for many, many patients. Myron, I'm curious, and maybe if you can answer both in the context of the hospital as well as in the context of the vaccination efforts. In terms of what were some of the challenges that your organization faced?
Yeah, so I'll speak first to the hospital because I think that lines up nicely with what Jeni said. If you think about your hospital population, maybe you're thinking people who are not dissimilar to us, right? Folks who may have better insurance coverage, who are able to self-select for their acuity of care. What does that mean? That means that in general, we have this mindset that says, hey, if I deserve urgent level care, I'm going to go to an urgent care center. If it's non-pressing, I'll go to my PCP. If it's an emergency, I'll go to the emergency room. But what we're finding is that that's actually not true in the larger context. There are a lot of people who go to the emergency room to seek non-emergent care. And the reason for that is because for a lot of these folks, they feel that there are no options outside. Right? The emergency care will see you regardless of your insurance status. The emergency room is a hub of the community where you can go. You don't have to pre-plan, finding your primary care physician. And that becomes a challenge twofold. One, because it does gum up the system for folks who are experiencing true emergencies. And then second, it also makes it not the right level of care for those folks who are now racking up emergency level charges, right, for non-emergent care. So the challenge becomes, how do we as a hospital expand our campus and our program offerings to let these people be seen outside? There's a very interesting quote that I'm going to misquote here that basically says, in America, we don't actually look at health care, right? We look at health treatment in the hospital. So much of our healthcare is focused on, you come to my four walls, let me treat you, send you out. And we're slowly starting to see this paradigm shift to, how do I take care of you so you don't have to go to the hospital? And that's sort of the big organizational barrier. For the vaccination clinic, I also want to echo something Jeni said, which is that data is king, right? So when San Diego County and in partnership with Sharp Healthcare first opened the super stations, we knew where the disproportionate cases of COVID were in our community. That would be in the South Bay near the border to Mexico, and in the East County, as you get to more suburban rural areas. So we opened up super centers there, and with the vaccine supply, we were getting maybe around 2,000 shots a day, just as a number. And we were filling those up real quick. And if you're a naive operational manager, you would say, hey, here's 2,000 patients we're seeing, good, let's keep going. But if you are able to be efficient to the point where you're able to analyze your data and remember your cause, which is that you're here to support these communities, then that data will show you, hey, a lot of these folks are actually traveling from more affluent areas, like in North County, driving the 40 minutes to these centers to get their shots. And how does that sort of run contrary to what our stated mission was? And what special things do we do to make sure that we're able to to provide equity to those folks who may have access challenges? And that became one of our biggest organizational barriers in running those COVID vaccine clinics.
Got it. Thank you so much, Myron. Yes, a lot of what you shared definitely resonates. Transportation can be a huge barrier for many in terms of access to healthcare. So location is certainly important. Great. And I would actually love to turn it over to Francisco to share some of the challenges that Promesa Boyle Heights faced in its journey.
Thank you. So I think, unlike some of the other panel guests here with us, and maybe folks that were at the conference all day, we are a community-based grassroots organization. So we're not providing like direct medical services ourselves. What we function as is a hub to pass that information and that knowledge.
Uh-oh. Looks like we may be having a little, there he is.
Yeah.
Sorry, Francisco, you froze there for a second. You're back.
Sorry about that. So I will just briefly reiterate that our role is to get information out to the families that we work with. We as a community-based organization serve that function, and the way we do it is by doing capacity building with residents to do the outreach, to do the information sharing, to connect those resources to the families in our community, the same families that you may have been talking about all day today that have the least access to insurance, that have the lower life expectancy, that have conditions around them that impact our health, such as like in Boyle Heights, pollutants in the air, right? All these determinants of health. So operationally, we had to readjust and think about, how do we get that reach? And we had to pivot and replan and think around how we build a actual network within our community. That was quite a challenge. That was quite a challenge for us, but we've been able to. And one way that we've had to adjust our approach to this was the understanding that this is like a walk, right? It's not a race. It's going to take some time to turn the tide to, decades and decades of lack of access to this information and resources. So knowing that, we kind of had to adjust our expectations of how fast we were going to get to the place we wanted to be, which is a healthy, thriving, resource-rich Boyle Heights.
Got it. Yeah, I'll stick with you, Francisco. I know we've touched a little bit on, I've heard several panelists talk about the value of data. I'm curious for several of the programs that you've referenced, how did your organization measure success? And what were some of the positive results that you saw based on those success measures?
One of the ways we were measuring success early on was, where are the numbers of folks that we were reaching, the residents reaching residents? Were we referring a lot more folks to the local resource center, where at that resource center, they give you that information on how to apply for some of the insurance that you resource. There's so much programs out there that help working class families, people of color families in our neighborhoods that we don't tap into because we are not aware of these programs. So, resource hubs like are we flooding the streets in our community with information at the level of like saturation level, And so each year we try to increase the amount of literature pieces, signage that are out there, because that's kind of, those are the markers, those are the arrows that point us as communities to the right direction. So we don't feel like we're out there all alone. We also, I think we measured a really powerful, I think, impact we had was participating in the Los Angeles County Public Health Department's Center for Health Equity. We feel that we made a great impact as community-based organizations and informing, the long-term plan of what it's going to take to reach health equity. And that plan, health equity plan for all is an amazing document that really captures all of our voices. So I think that by itself was a very powerful achievement, I think, because it's a blueprint for other communities, I believe.
Wow. Yeah, that's great. So Myron, you spoke to some of the challenges that you face both on the hospital side as well as with the vaccine clinic. Can you share some examples of how your organization overcame some of those challenges? And then I'd also be curious in terms of measuring results and what were some of the actual results, what some of the KPIs that you all leveraged?
Absolutely. Let's talk about the vaccine clinics, right? So I mentioned a while ago how you can't just have a naive measurement of were all my appointment slots taken. There has to be an EDI angle to it because that was the mission. So what we did was we were operationally, we were able to partner with local nonprofit and county organizations like the Promotoras over in San Diego County, who actually knocked door to door to give that information to, families that wouldn't have otherwise thought to seek out that information on getting vaccinated. We also set aside a certain allocation of vaccine for what we call Project SAVE, which is safe access to for vaccine, or speedy access for vaccine equity. And what it is, basically, it answers the question of, as we develop these processes of how we roll something as big as a vaccination drive out, we default so strongly to the internet, to making your appointment by phone. And we have to realize that a lot of these, there's a significant number of people that don't have access to that. So you have to allocate, for walk-ups, for folks with access issues. And how we tracked that was we looked at the zip codes we were at, we looked at the eligible populations in those areas and saw how much of a penetration we were making. And I'm very proud to say that in the South Bay area, which was disproportionately hit with COVID and which has a history of low medical resource availability, we were actually able to hit 99.2% of the eligible population getting their shots, which is unheard of, right? And that's not just sharp victory. That's a victory of the local organizations that were empowered to do what they did best. Because I'm not going to come in and pretend that I know how to reach these communities that, I'll be frank, maybe I had not been as integrated a part of, right? And in the hospital side now, when we look at these programs, whether it's through the Joint Commission, through CMS, there are a lot of good benchmarking studies and benchmarking goals to try to reach for equity and diversity and inclusion. And, by meeting those goals, standards, for example, at our Sharp Grossman Hospital, we were recently credited with being a geriatric safe emergency room. That's where you start thinking, oh, look at that KPI. We were able to meet, a whole host of measures, whether it's mortality, readmission, hospice admission, patient experience. And then that's how you celebrate that you were able to make it. And as a real quick comment, I just want to make, I think it's easy for a lot of us to think of equity, diversity, inclusion as it subsects through, let's say, race and ethnicity or through gender. But I want to remind everybody that EDI also goes beyond that, right? It goes to folks who may be suffering from disabilities, whether physical or mental. It also includes people who may be LGBTQ+. And we're seeing that depending on the intersectionality you look at, there are huge disparities there. And you have to tailor your approach based on what intersection needs that intervention the most.
Absolutely. Yeah, that's a great call out. And wow, 99.2% vaccination rate. That is absolutely incredible. I love hearing how you leverage local partnerships with other nonprofits. That is incredible. Congratulations. Jeni, I'd love to go back to you in terms of some of the ways you addressed the challenges, and then how did you all think about measuring success?
Yeah, so looking at the two issues that I highlighted, one, leadership, and then two, having the data, there were a lot of things that we had to consider with all of those data points. At the end of the day, leadership to some extent is also a data point. How are we hearing about physician leaders in the local market? Is it, because they're getting promoted? Is it actually off of clinical quality? How are we actually hearing them? And we do have the data on our physicians. So it's bringing that in, figuring out, hey, who can we tap into to get their view on how we can address the issues in their local markets. And that's been really fun to work on. Today, it's also looking at how are we recruiting. So I really love looking at the trade shows that we've got lined up right now and thinking about, okay, who's the audience here? Can we actually change the audience to some extent? Because clinicians have historically been very monolithic in who they are. And can we actually, invite other people to those trade shows alongside us? But it's not just our representatives there bragging about Envision. It's about us really bringing the community along with us. On the data front, I think the hard part for us was figuring out what data don't we have and how can we tap into that correctly. One of our women's and children's projects, for example, we surveyed patients afterwards and we had a question about their household income on there. I don't think a ton of people immediately think of that as, oh, patients, won't care about that, but they actually do. It affected whether or not they came back for a follow-up virtual visit. And so we wound up taking that question off. It's really fun kind of digging through the data. And we actually have an entire team of nurses here, our directors of clinical service, who really run these plan, do, check, act processes to make sure that we're constantly improving on our outcomes.
Love it. Those are great examples, Jeni. All right. Let's see. I think I'll circle back to Kathi to help us with this next question. I'm curious if you encountered any surprises along the way, and if you could shine a light on one specific activity that really helped your organization improve health equity, which one shining example would you speak to?
Yeah, so I wouldn't call this a surprise because I had mentioned in the beginning, I didn't mention it, but in the beginning, one of our strategies was to have a promotora model. And it took us several years to get to this point. And in 2018, we were finally able to onboard promotoras. And so now we have wellness promotoras, we have COVID-19 promotoras, and we also have healthy environment promotoras. And in case you don't know, a promotora is essentially a promoter. And so wellness promotora is pretty much promoting just health and wellness in the community. And what's special about a promotora model, especially at Promesa, is that we onboard and we hire people from the community, right, who look like the people in the community and who speak the language and who know the resources in the community, who can guide, who can point to where someone needs to go to apply for health insurance or for any other support. And they also are able to ease some of that anxiety, right? They are the listeners in the community and can really support. And so I'll talk specifically about our COVID-19 promotora. So last year we shifted, as many other organizations did, and we focused because our community, Boyle Heights, was impacted by this illness. And so we gathered a few promotoras, and we were sharing county resources that included either, where to get tested, vaccination sites, and then also food resources. We also heard that people were facing insecurities around food. And so, through the curriculum that we developed, we were able to set out promotoras in the community, at community spots, at parks where we know people, walk by, and we were able to share all of these wonderful resources. And from February 2021 until December of 2021, we were able to reach about 1,000 people with information, and not just reach, but we, make connections and talk to people about COVID-19, about the vaccine. And like I said earlier, easing people's anxieties, right? Like there aren't many people who are willing to listen. And so our promotoras played a crucial role in being able to, just be there for our community.
Wow, that is incredible. We all know that healthcare is local, and what better way to tap into local resources and really spread information through that Promota program than by actually leveraging members of the community themselves. I'm curious in terms of finding or identifying folks interested in serving as promotoras. Can you talk a little bit about the process? Were those hired positions, volunteer positions, a combination?
That's a great question. So, initially we started as a system navigators and peer educators role. It was kind of like a trying it out to see what it would look like. And it was people that we, as Francisco mentioned earlier, building their capacity, through leadership academies. And we had identified a few people already that were kind of ready for the next level, right? Like they were ready to take on something bigger. And so we onboarded, we provide stipends for our promotoras who do the work, and they go through a curriculum. So we develop a curriculum for promotoras, especially for, the different areas of the work requires different skills. But for wellness, we definitely have a curriculum that is centered around relationship building and connecting with people, listening, and providing a lot of empathy. So I hope that answers the question.
It does, yes, thank you. Those are all important soft skills, no matter what we're doing. So thank you for that, very helpful. Myron, I'd love to go over to you in terms of any surprises that you encountered along the way. And then if you could share one specific activity, maybe both on the hospital side as well as on the vaccination clinic side, that you are most proud of in terms of really improving healthcare equity.
Yeah, so starting again with the vaccination world, one of the surprises that I discovered, and I'll be honest with it, I'm a little bit disappointed that it came as a surprise to me, is that the people on the fringe, or the people that we think are on the fringe, there's a lot more of them than we think. The only reason why we think they're on the fringe is because we've chosen to either not listen to them or to not let them be heard, right? So when we think about the folks who, maybe undocumented residents who may have certain disabilities, certain language barriers, it's easy for us to think, oh, they're a minority. But once you actually put in the effort to reach those folks, you'll realize, wow, this is actually a huge part of my community. And I can't believe that we haven't been reaching out to them, until now or until whenever. Let me share with you a very quick story. For example, I try to give these huddles at our COVID vaccine clinics in the beginning. And the transition happened when the first phase was, for folks 65 and over, and then we were going to open it up to people in essential industries and, restaurant workers, et cetera. And one of the big learnings there was, hey, the reason why we're opening up the next category is because we've reached a certain percentage of people 65 and over getting their shots, right? So maybe let's ballpark it at 95. And so you have 5%, you're kind of going, you know what, we can't wait for those 5% to get it. Let's open up the next shop. But then what you realize is those 5%, they're probably disenfranchised and they can't find that access. And if you now open up the next layer, where now you have tens of thousands of people who are much more technologically savvy, that 5% gets compoundly disenfranchised, right? So that's why it's so important for us to create this equity work to reach out to those that don't get that first cast of the net. And again, let me remind everybody that this is a bigger proportion of your community than you see, because they're not the most visible, they're not the most easy to listen to, but they are there. And then the hospital side, same thing. It is easy to fall to heuristics. I mean, I think a lot of us here who work in healthcare would have heard one way or another about studies in the past about people of certain racial backgrounds, the Black community, getting disproportionate care as their pain management, as a very simple example. And, it's very difficult to come to terms with that, because you want to either think, oh, that's everywhere else, not in my institution, or, oh, that's only on an individual basis, not systemic. And you really have to start addressing that from a no, we are all at fault in this. Equity shouldn't be something that we are trying to introduce. Equity is something that we owe to our community, that we are now finally realizing, oh, we need to make up for the fact that we haven't had these programs before. We should have started this yesterday. And so, now introducing things such as multimodal pain management, branches in the emergency room to treat the appropriate acuity for folks who can't self-select. Having those sorts of products in which aren't glitzy and glamorous, you're not going to get 10,000 new visits, but the ones that you do get, it's going to impact the community a lot more. So it's more of a surprise in mindset that I think a lot of us want to say we know about. It's just something that we don't confront ourselves daily with.
Man, very, very insightful thoughts, Myron. I appreciate you sharing that. We are actually running a little bit ahead of schedule. I'd love to circle back with our panelists just one last time before we open it up for questions, to see if there was anything else, any advice that you have to offer for for our attendees on the session, based on your experiences, either with your current organization or maybe a prior organization even. And let's see, Myron, I've got you next to me on the screen. We'll maybe start with you.
Sure, I'll give 2 pieces of advice in the capacity that I can. The first is, make sure you have the voices at the table, right? So I know a lot of our folks here, if we have a lot of Anderson students here, a lot of people might be trying their BCOs, create, their entrepreneurial legs, trying to create their own technologies, their own companies. One thing that I have been very humbled with is that you can be as woke as you think you are, but that will never be a substitute for the authentic voice of a community that needs to be represented. So if you are going to make a technology that seeks to promote healthcare in your community, please, please, please invite team members of your community and their diverse backgrounds. And like I said, that's an intersectional thing. That can be gender expression, sexual orientation, race, ethnicity, ability status, right? And so please don't assume that a thinking head can substitute an authentic voice. And the second thing that I would actually advocate for is, a lot of folks tend to look at operational efficiency and EDI as 2 separate buckets, right? But I actually am a fervent believer that it's intertwined. Because if you are not efficient, if your company is not efficient, if your healthcare delivery is not efficient, you are spending all of your energy treading water, and you will not have the energy to be daring, to be creative, to manipulate data in such a way that answers questions you didn't even know you had. So I would actually say to a lot of folks who maybe work in larger organizations, advocate for efficiency in operations, because once you're efficient in your operations, then you can have the bandwidth to start asking the deeper questions of, am I serving the right patients? Am I reaching my community the way I should? Or if you're not, what can we do about it? So I just want to, again, it's a very philosophical mindset thing, but it's something that I've had to wrestle with in my professional career. And I think healthcare organizations have had to wrestle with, knowing that we have had a legacy of not, being the greatest advocates of equity, diversity, and inclusion in our communities, just from historical knowledge. And I'm very proud, actually, that Sharp Healthcare has made a commitment to really pursue this sort of work in our community.
Those are 2 great pieces of advice. I appreciate you kind of helping us think about an expanded definition, or who are we really talking about? And then I love your advice around ensuring that everyone has a voice at the table. We have a slogan that we use often at DaVita: nothing about me without me. And so your advice and comment really, really resonates. Let's see, Jeni, I'd love to hear from you. Any parting thoughts or advice that you'd like to offer based on your experiences?
Yeah, I am in a similar vein with Myron right now. Make sure that there are people at the table with you who reflect your community. And especially today, as a leader in my organization and having the ability to create room for others, that's one of the things that I love getting involved in. It's the recruiting at various schools, being able to recruit at different, not your usual health fairs or college fairs, really being able to advocate for that. And then on a day-to-day basis, looking at my audience and going, is this actually reflective of our community? And then the second question that I think about is, how could I create space for someone behind me? Because I know that there have been a lot of great women who have broken through the glass ceiling before me, and I gotta help them, gotta help the people behind me too.
Thank you, Jeni. Appreciate that. Let's see, Kathi, over to you. Any final thoughts or advice that you have based on your experiences?
Yeah, similar to what the two panelists have said about bringing people different than you at the table, also being able to employ some cultural competence. Once you have someone like people of color at the table, being able to really have the ability to understand, appreciate, and just believe, right? Believe people's what they're telling you, their perspective. I know that communities of color, Black and Latinx communities report less pain because doctors don't believe that they're really in that much pain. So I would just say that aside from having people at the table, it's also believing them, appreciating, and being able to understand and empathize.
Great. Thank you, Kathi. Yeah, it's one thing to have a seat at the table. It's equally important, though, to really create that sense of belonging amongst those at the table. And Francisco, I don't want to leave you out. Any parting thoughts or advice that you have to offer to the group?
Yes, thank you. I really appreciate some of the comments Myron said. Myron, I appreciate you bringing the intersectionality lens into this. The public health department's Center for Equity, Health Equity, really looks at the totality of the circumstances that communities are living in. Good schools, safe and supportive communities and neighborhoods, thriving inclusive economy, quality healthcare. We're talking about that. Strong social connections, and sustainable, healthy environments, right? So it's all these multiple things. And one of the things that has been uplifted quite often in the workshops, because one of the things Kathi was mentioning around the promotoras, they do a series of workshops, and really to bring one of those elements in the strong social connections and information sharing is the importance of taking care of oneself, right? The preventative element of our health, right? The food we eat, the exercise or lack thereof, right? These kind of things are so crucial. And so whatever we can do to have that lens around preventative, upfront, front-loaded access to that type of information and recommendations on health choices would be instrumental to the future of a community that has health equity.
Mm-hmm. Yeah, that's absolutely right, Francisco. Thank you for sharing. I think Myron alluded to this earlier. It's very much a paradigm shift. It's one thing to treat those that are sick. It's a completely other thing to keep everyone healthy. So kind of two different approaches to that. Well, I have learned a ton from our panelists. Thank you so much for sharing your great experiences, advice. At this point, I would love to open it up and allow an opportunity for our attendees to ask questions as well. So Raul, I will turn it over to you to help facilitate the Q&A.
Thank you, Paige. So if you have not had an opportunity to enter your question in the Engage platform, please do so right now. We have some questions coming in, and I'll try to get to as many of them as I can. So the first question we could bring here is, so it sounds like information is the biggest challenge. Is there something else that I might be missing?
Let's see. Myron, would be curious your thoughts on that.
Yeah, so am I understanding this correctly, Rule? So basically, we've come to a consensus that information and the processing of information is a challenge, but what is the missing link? Is that what the question is?
It says, is there something else that we might be missing? So I think it's individual, hopefully I'm getting it right. They may be wondering, is it just information problem? Maybe there's a income problem or deployment problem, something else. Yeah.
Yeah. So in very broad brushstrokes, let's put it this way. We've all heard the idea of data rich, information poor, right? I would actually say, I think we're graduated from that and now we're information rich, decision poor. It's something that plagues a lot of companies, healthcare companies included. We get a lot of information. We know a lot of things about our patients, but it does become difficult about how do you implement strategies that are effective for those communities. So in a microcosm, right? We know that we want to provide outside emergency room options for folks. We have the information that says that. What percentage of our patients are actually not here for emergent care? We can dream up all of these other programs we want to launch. But because of the human condition or just what we're able to do, it's so hard to implement that. So I would say right now we are becoming good at getting information in, but it's becoming difficult to actually execute those in programs that that work. And I'll be honest with you, one of the biggest challenges there is the business of it all, right? A lot of work in EDI, I'll be quite frank, is not profitable. So it's not attractive. It is, very intrinsically tied to grants and tied to reimbursements from the government. And so as you dream up these new programs that'll help your community, you have to be creative and ask yourself, how can this be funded? And that's yet another layer of challenge. So again, I want to, challenge the MBA students here in the audience to understand that also, as you start doing your market research outside and what you can do to take this information and make it happen, how do you make that happen knowing that there's so many barriers around you and that it's not the most glitzy and glamorous option out there?
Thank you, Myron. Another question here, maybe, or if anyone wanted to speak to the previous question. Okay, we'll move on to this one. I think this one's interesting.
Myron did a fabulous job answering that one. And I would just add on, I completely agree. Having the data is important and helpful, but in some ways it's just the tip of the iceberg. It really becomes then, what do you do with it? How do you execute on it? How do you fund the opportunities and insights that come out of the data? So thank you for that, Myron. Raul, let's go to the next question.
So thoughts from the speakers regarding healthier food options in communities of colors. Should healthcare companies, and I guess related industries, be doing more in this regard? I guess it would be, is the responsibility of these healthcare companies also to now consider healthy food options in communities?
Interesting. Kathi, I'd be curious to get your thoughts on that one.
Yeah, I think, as Francisco had said, right, there's a lot of diseases that are preventative, and this Promotora model that we've been talking about is about preventative health, and food definitely is one way that you can take care of yourself. And we also know that there's in communities of color, there are food deserts. So it seems like a contradiction that communities of color, we want them to be healthy, yet there isn't enough food, and then they go to the hospital. So it becomes like this cycle, right? This never-ending cycle of people just going to the hospital, and not having any preventative care. Or so to me, it makes sense that healthcare or healthcare clinics, be doing a little bit more to help in these, food desert areas and communities of color, and being able to talk about healthier food options, and not just healthier food options, but foods that also encompass like their culture, right? Like, and the whole person, like we said, Promesa is about the whole person, and not, so when we talk about healthy foods, it should also include foods that are culturally relevant to them, that are healthy, that they've been eating this whole time, so that, people don't feel like everything that they eat is unhealthy, or, so just definitely more knowledge, more education on their part, and just going back to the whole cultural competence piece. Yeah. Thank you.
Thank you for that. Yeah, Myron, I'm curious if you have any additional thoughts regarding the question, the topic of food options.
I do, and I
think, is that the response of healthcare providers?
Yeah, I think that Kathi highlights something very important, which is this sort of revolving door. Very simplistically, let's talk about heart failure patients, who out in the community may not have access to good, nutritious food. So they become fluid overloaded. I'm sure you're familiar with this too at DaVita, knowing our dialysis patients. They come into our hospitals where they're able to receive a healthy meal that is, nutritious and diet controlled. Lo and behold, they get better enough to discharge, but then they do come back in 30 days, and that's one of the charges. How do you look outside of your hospital to see what's going on outside? How do you partner, with local organizations, either food banks, Meals on Wheels, to allow those folks to have that nutritious food? And I want to highlight what Kathi said also. It's about cultural competence. So many patients receive sort of what is a heart healthy diet based on a traditional Western diet. In San Diego, a lot of people don't know this, but we have a large community in the African diaspora of Somali refugees. And for years, we've been seeing increased diabetes and heart failure in these populations. And that's because a lot of the food education to them is not culturally competent, not culturally relevant. So I think there is a burden on healthcare providers to educate in a culturally competent manner, but also to partner with local organizations to be able to provide that food to them. And it's across all ages. I mean, something as seemingly distinct as, free school lunches for kids can help with adult populations, because it is not untrue. It is very true that parents will choose to not eat to feed their kids, and so even if you have a after school program or a during school program for the kids, that helps the whole family. That helps the entire multi-generational home. So yes, and again, this is changing that paradigm, right? I'm sure when we ask, should these healthcare companies, we tend to think doctors, but again, food is health. So yes, there is an opportunity there. Just as a quick plug, DoorDash actually partners with a lot of hospitals now to deliver dietitian-approved meals for patients on special diets, which I think is pretty cool, so that these folks don't have to go outside of their neighborhoods if they're in a food desert.
Wow, did not know that. Great. Thank you for that, Myron. All right, Raul, do we have other questions submitted?
Yeah. So this one starts with what's very true. Our healthcare system is very complex, and many consumers, they'll lack the understanding of this complexity. So we'll start with that. And it says, what will it take to help bridge that gap between consumers and providers/payers to ensure more equitable care? What's it going to take? Closing that gap.
Yeah. Thank you for that. Jeni, I would love your thoughts on this one.
Yeah, it's a really fun one to look at, bridging that gap between patients, providers, and health plans, because I think all of it is related to each other. And how do you really think through those gaps? It really takes leaders at the hospitals with physicians and the health plan too. And it needs to be thoughtful. It can't just be hey, we want to make sure that vaccination rates are consistent across every race, ethnicity. It's got to really look at how do we partner to invest together in that. And that's one of the things that's been fun to talk to health plans about is, hey, if we're going to talk about shared savings or any of the new payment innovations, what's really needed from us? How can we invest in this population together? Where can we go and engage the government? That's one of the things we've been doing with ET3 is we're actually talking to CMS right now and showing them the data about what our patients have actually needed and then what kind of health insurance coverage they actually have. Because if that program's only covering Medicare, it really is missing out on about half the patient population that needs it. So there's a lot of room for collaboration here, and it really starts with coming at it from a partnership perspective. Paige probably called on me because I was on payer contracting, and I think a lot of organizations have historically been at odds with each other. Hey, I'm a doctor, you should pay me $50 for an x-ray. The next year you should pay me 55. But it's really more than just that. It's really going, hey, for the $55, here's what our patients are getting. Here's the way that we can look at it, and really thinking through that bigger picture and building a relationship.
Thank you, Jeni. Very helpful. Yeah, I have an opinion on this one too. I think one potential solution to really help bring patients, providers, payers, to bring everyone together is very much what we're experiencing now with the shift from a fee-for-service world where it's all about paying for specific services over to more of a value-based care world, which really forces the collaboration amongst all the key stakeholders. So I'm quite excited by that shift and agree that there's a big opportunity. Myron, I'd be curious your thoughts on this one as well. What else is it going to take to truly bridge the gap and bring patients, providers, payers, all the key stakeholders together?
So the easiest answer is we need a magic wand, because this is a huge problem. Great minds have tried to tackle this. The CVS Berkshire Hathaway merger recently fell through because they found this such a difficult topic to look at. I'll answer in 3 very short pieces. 1, organizations like Promesa Boyle Heights are doing, God's work in bridging this gap, getting folks to talk about their health inside and outside of the healthcare walls. Number 2, I think we need to recruit more PCPs, more primary care physicians, more preventive medical care services, because sometimes you need an expert who can explain these things to you, right? So if you have insurance and you're able to see your PCP, they can tell you the value of pre-hospital care. They can guide you. Navigators are such a hot term right now in the healthcare space, as they help you navigate through the healthcare journey. I've never needed a navigator when I'm going down a straight path. So that's proof positive that it's a very convoluted area where you can get lost, right? So that navigator trend is great. And the third, and I think the most important part in this, is it's not something that we should do. It's something that we should be cautious against when we're doing, which is that there's a huge shift right now toward consumer-driven healthcare, consumerist healthcare. You're seeing, One Medical, Forward, all these things that supplement your health plan for more consumer-driven healthcare. And what that's doing inadvertently is that it is expanding the gap, because now you have highly technical, literate folks who are able to, participate in these at-will healthcare programs, and you're really building it that way, which means you're widening the gap between the haves and the have-nots who don't have insurance, don't have access to those, paper service at-will programs for their health. And that skews the picture. So, I know I keep hammering this, but that's because I believe in Anderson students. As we look at healthcare and how do we build businesses in healthcare, one of the things that will help is by not just focusing on those with disposable income and very, very good insurance, and how do we instead really look at the entire scope of our community?
Great thoughts, Myron. And I know we're down to just the last couple minutes. I think we have time for another question. So I will start by saying a huge thank you to all of our panelists. I'm so grateful for all of what you shared with us today around your experiences, your advice, your insights. I know I learned a lot, and Raul, I'll turn it over to you to see if you have any final thoughts as well.
Yeah, finally, we did have a question here regarding the resources and where could I go to learn more. I certainly think there's one organization here we discussed, Promesa Boyle Heights, might be a resource where someone could not copy their model, but certainly learn a lot about what their journey and maybe take some of that home to your own organizations. And with that, I would just like to thank everyone for joining us today. I think it's been incredibly insightful, and hopefully we can have a virtual round of applause for everybody. Thank you very much. And you all have a great weekend. And if you're still staying on for some of the additional Vitals programming, I'll see you there.